Happy Easter, everybody. So maybe you noticed at the end of my last installment there that I cut myself off, and at that point I decided to call it a day. And so here we are on a glorious Easter morning and getting back to work a little bit. So um, I wanted to continue with our discussion of medical anthropology, and we were talking about critical medical anthropology. And what we said last time basically was that what critical medical anthropology uh, argues for is an institution, right, of medicine that pays more attention, among other things, but pays more attention to structural suffering, structural causes of health problems, and so forth. And we're gonna talk a little bit more about that as we move along here. But we also said it had well, before I move on here, pay more attention to structural suffering, and is very critical of the notion of the medicalization of poverty. That there are many problems that and many factors that influence human health, um, and they are like social problems. They arise from political arrangements and economic arrangements and so forth, especially all those that have to do with poverty. And the response of much of the medical establishment is to medicalize those problems, to treat them as if they were medical problems and not social problems. That the underlying cause of many of the world's health problems are actually structural, and that's what they're calling for, is addressing these structural issues. Um, but we also said that critical medical anthropology is going to address the institution of medicine itself, Western biomedicine, and in this case, we're going to talk about the patient-doctor relationship and medical training. And then a third issue that I wanted to add is the issue of culturally specific syndromes. So that's where we're heading, I think, in this part of the discussion. If I can hold the technology together and not keep screwing up, but we'll see. Okay, we'll get it all done eventually. But here we go. All right. So we're continuing with our discussion of critical medical anthropology, and I wanted to begin with this idea here. Okay, this idea here that from the point of view of critical medical anthropology, the Western biomedical model is a cultural healing system, just like any other cultural healing system. It has many benefits, but it also needs a great deal of improvement, and that's the areas where it needs to be improved. I think that critical medical anthropology is addressing. So one of those areas, as we said, is the issue of structural suffering, right? That there's a great deal of social inequality and poverty. And across the world, poverty is the primary cause, the underlying cause, right, of sickness and death. And it gets manifested in a lot of different ways. And also critical of this whole idea of the medicalization of poverty. So we talked a little bit last time about Nancy Shepherd-Hughes's article. I read you that quote from Miller where she's discussing Nancy Shepherd-Hughes's work and using that as an example of the medicalization of poverty. So you can go back and look at that stuff again if you want to. Okay. The next issue that we're getting into is this the overall critique of Western biomedical training and the orientation of Western biomedicine, and that's going to include the nature of the relationship between doctor and patient, right? This kind of private system. And the idea that Western biomedicine is heavily reliant on technology. Now, the fact that it's heavily reliant on technology, has its benefits. Definitely has its benefits, right? I'm here to attest to that personally. It has its benefits, but also, what are some of the drawbacks maybe that go along with a heavily technical orientation or a heavy reliance on technology that Western biomedicine exhibits? All right. Okay, so first thing, right, treating the body as a machine. Now, I have a quote here from Daniel Chambliss, and he talks about this. I want to get the first, in fact, I want to get all of these up here. Okay. Treating the body as a machine. So this quote comes from Daniel Chambliss. Now, he wrote a piece that you were going to receive in class, but I can't get it to you, and I can't get a link to it anywhere. So I just wanted to talk a little bit about his work, and maybe you want to remember this quote. Okay, well, not memorize it, but just like remember what he's talking about in here. And it has to do with the problem of treating the body objectively. The name of this piece that I was going to give you from Daniel Chambliss is called "The Patient as Object," right? Not the patient as a person, but the patient as an object, right? And in this case, the patient's body as something akin, right, to a machine. So Daniel Chambliss said, right, that patients do not experience illness as symptoms. And here's illness. Remember what illness is. Illness is the way we experience disease, right? Patients do not experience illness as symptoms that can be mapped onto a medically diagnosed syndrome. To the layman, to you and me, to the layman, the body is a sacred thing, right? Not to be handled and used lightly. It is, though, a very different sort of object to the physician. So there's this discrepancy, right, between the way the patient understands his or her own body and the way that the doctor, as a doctor, understands the body of the patient. Okay, I think that's some interesting language there, that the patient is more than just symptoms, right? That the body to the patient is sacred, has sacred meaning, it's special. Okay, everybody, I hope everybody's with that so far. And so in this article, he goes on to talk about how that the doctors, or I should say medicine, Western biomedicine, objectifies the human body in this way. Now we'll say, right, that there are going to be some drawbacks to that, right? There's some disadvantages to that, about that for the patient, but there are also some advantages, right? This is the kind of thing we got to get here, is that there's positive and there's negative aspects to all of this stuff here. What do we as patients gain by the doctor treating our bodies as machines? What do we gain? What do we as patients gain by doctors treating us as objects? But also, what do we lose? So we want to talk about all that stuff there. And this notion of treating the body as a machine, comes from the fact that Western biomedicine is going to emphasize a technological model. Okay, I wanted to read a quote again to you from Barbara Miller, where she talks about this. I want to find it here if I can. This is going to be embarrassing because I probably can't find it, but I want to try. So just be patient with me for a second. I should have thought this through a little better. All right, but hold on. Let me get it. here. It's on page, it starts on page 106 and it goes over to page 107 where she's talking about, Barbara Miller's talking about obstetrics. Okay, so here's what she says. All right. She says, some critical medical anthropologists have conducted research on Western medical school training. One study of obstetric training in the United States involved interviews with 12 obstetricians, 10 male and 2 female. As students, they absorbed the technological model of birth as a core value of Western obstetrics. The model treats the body as a machine, right? The model treats the body as a machine. The physician uses the assembly line approach to birth, in order to promote efficient production and quality control. One of the residents in the study explained, okay, so here's a quote from one of the residents. We shave them, we prep them, we hook them up to the IV and administer sedation. We deliver the baby, it goes to the nursery, and the mother goes to her room. There's no room for niceties around here. We just move them right on through. It's not hard to see it like an assembly line. The goal is the production of a healthy baby, right? The doctor is a technical expert. The doctor is a technical expert in charge of achieving this goal, and the mother takes second place. One obstetrician said, quote, it is what we all were trained to always go after, the perfect baby. That's what we were trained to produce. We rarely thought about that. Everything we did was to get that perfect baby, right? This goal involves the use of sophisticated monitoring machines. One obstetrician said, I'm totally dependent on fetal monitors because they're great. They free you to do a lot of other things. I couldn't sit over there with a woman in labor with my hand on her belly and be in here seeing 20 to 30 patients a day. The use of technology also conveys status to the physician. One commented, anybody in obstetrics who shows a human interest in patients is not respected. What is respected is interest in the machines. Okay, so you get this, you get some key words in there, right? Describing this whole process as an assembly line, right? You know, the patient as really like an object of production. Okay, now, you know, if you think about, you know, a regular assembly line, like an automobile assembly line, right? It's like standardized, you know, and it doesn't matter, right? It doesn't matter who the doctor is in this case. It doesn't matter who the worker is. It doesn't matter in this case who the patient is. They all become like the same, okay? So they're not treated, you know, the patients are not treated as necessarily, right, as unique, whole people, okay? They're treated, in this case, as objects, right? But you all get that, right? The body is treated as a machine. Now, one thing we could say is if the body is treated as a machine, then what that's an example of is dehumanization, right? The patient, the arguments being made here, the patient is dehumanized by being treated as a machine. And we're going to come back to that, right? What does that dehumanization mean? Okay. So we have this treating the body as a machine. We have this technological model, right, within which these doctors are working. And, you know, it shows when we hear this comment, right, and it's from a long time ago, so maybe things have changed since then, right? But when we hear this comment, anybody in obstetrics who shows a human interest in patients is not respected. Okay, so we're going to talk about, well, then where does that kind of attitude toward the patient come from? It's going to come from medical school training, right? From the enculturation of medical students. And like I said, now she's quoting an article and she's quoting work that was done back in 1987. So maybe things since then have changed. Um, I think it's maybe still an issue, but maybe things are changing, or maybe they've changed, or they're on their way to changing. I know there's much more emphasis in medicine these days on patient-centered, um, patient-centered, you know, medicine. So, you know, I'm just going to mention that just to kind of be fair here. All right. So, but I'm really talking about it the way that Barbara Miller's talking about it. All right. So is everybody good so far? So now we're going to talk about this enculturation of medical students, right, through medical school. What happens to students in medical school? Now, the way you want to think about medical school, right, is that medical school is a process of enculturation. It's a process of a certain type of enculturation. It's a process of professionalization, right? Some of you guys are going to go on to graduate school and you'll experience this firsthand, where graduate school becomes this sort of socialization process into the values of a profession. Okay, so medical students learn to accept this technological knowledge through enculturation. And now we need to understand that that medical school education, what that medical student goes through, right, from the time they enter medical school to the time they finish a residency, let's say, is a long process of enculturation. And in fact, Miller describes it as hazing, and actually, you can get on the Google machine and you can read about this. You can read about, medical school as a process of hazing, okay? That it is a harsh rite of passage involving things like sleep deprivation and artificially created stress. So when I see that, right, sleep deprivation and especially this artificially created stress, right? This is the way that, for example, military boot camp works. Military boot camp is a very intensive process of re-socialization, of re-enculturation, of changing people in a very dramatic way. And it's done through the creation of stress, right? It's subjecting people to stress. All right. And in this sense, medical school is the same kind of deal, right? Where you're taking people who are entering that process with certain kinds of values, and you are recreating them into people with different kinds of values, right? So medical school becomes a kind of hazing, according to critical medical anthropology. And that one of the ways that it changes people is through this process of cognitive retrogression. Like how do you get people to come mostly to value the technology and come mostly to value the technical aspects, and to not emphasize the people, okay? And it's through this process of cognitive retrogression, a psychological process that encourages people to actually give up their critical thinking and their thoughtfulness, right? So giving up critical thinking and thoughtful ways of learning. And one of the ways that that's accomplished is by making medical students just simply memorize vast amounts of material, right? Vast amounts of material, and that forces them to be uncritical. The emphasis becomes not on a critical mind, the emphasis comes on memorization of material. And you're purposely, right, overloading these students with all this material. and that forces them into a uniform pattern, creates in them a kind of a tunnel vision. So let me get back here. Let me get back here to Miller, right? And here's what she says. She says, medical school training in the United States involves a process of cognitive retrogression. During the first 2 years of medical school, most courses are basic sciences, and students must memorize vast quantities of material. The sheer bulk of memorization forces students to adopt an uncritical approach. This mental overload socializes, that's an important word, socializes and culturates, right, students into a uniform pattern, giving them tunnel vision in which the knowledge of medicine assumes supreme importance. Okay? As one obstetrician said, medical school is not difficult in terms of what you have to learn. There's just so much of it. You go through, in a 6-week course, a 1,000-page book. The sheer bulk of information is phenomenal. You have pop quizzes in 2 or 3 courses every day the first year. We get up around 6, attend classes till 5, go home and eat, then head back to school to be in anatomy lab, working with a cadaver or something until 1 or 2 in the morning, and then go home and get a couple hours sleep, and then go out again. And you did that virtually day in and day out for 4 years, except for vacations. Okay, everybody get that? So it's this cognitive retrogression that gets people to sort of think in this sort of tunnel vision way. Okay. Right. And so medical school, medical training then works to submerge these humanitarian ideals by emphasizing technology and the objectification of the patient. Dehumanization. So I want to finish with another quote here from Miller. And Miller says, third, okay, in a process called dehumanization, medical school training works to erase humanitarian ideals through an emphasis on technology and objectification of the patient. One obstetric student explained, most of us went into medical school with pretty humanitarian ideals. I know I did. But the whole process of medical education makes you inhuman. By the time you get into residency, you end up not caring about anything beyond the latest techniques you can master and how sophisticated the tests are that you can perform. Okay. So again, right, what becomes primary is not the patient, but the technology. Okay, everybody understand that? And again, I want to be fair here. So, maybe since the time that this stuff was being written, things have changed. There's been a movement, I think, within medicine toward a more patient-centered medicine. How successful it's been in achieving this patient-centeredness, maybe it still has a ways to go, but maybe it's on its way. Okay, but anyway, that's where we are. All right. So I said before, right, that there are benefits and there are drawbacks, right, to even to this system, right? We ask the question, like, well, what do patients deserve from their healers? Well, they deserve, if possible, they deserve the best attempt to heal. Okay. And notice this question I have here. How are patients benefited, right, from their own objectification? And how are they harmed? Okay. Well, let's look at it like this. Let's take the second question first. How are people harmed, right, by their own objectification? Well, they're harmed by their own objectification because they aren't treated as full human beings, right? They're treated as objects, okay? They aren't treated as full people with unique needs and so on. Okay. Um, so that's not necessarily a good thing. But how are they benefited, right? How are they benefited from their own objectification? And this is something that Daniel Chambliss talks about in The Patient as Objects. Okay, he recognizes, right, that people are harmed. They're treated, as objects and not as people, right? But how are they benefited from that? Well, one of the ways they're benefited from that is if I am treated as an object, and if I don't matter, saying this kind of loosely, if I don't matter, then then I am going to get the same care, right, as anybody else, right? The doctor is not going to stand in judgment of me, whether or not I deserve to be treated. For example, is not an issue that would ever come up. Everybody, one of the things that objectification, as bad as it sounds, one of the things that objectification assures is that everybody is treated the same. Everybody is treated equally, right? So in an ideal world, okay, I would get the same care as, how can I, I'm trying to think of somebody really bad. I would get the same care as Jeffrey Dahmer, right? If Jeffrey Dahmer were on the operating table, the doctors would do the same to him to heal him as they would to me. And I don't know if I'm saying this right, but every objectification would mean that everybody is on the same moral level, okay? And therefore everybody is treated the same. Doesn't matter. It's an assembly line, right? So it doesn't matter what body is placed before that doctor. They are going to perform the same on that body as they would on the next body to come along. Doesn't matter who that person is. I hope that made sense. Okay. But still, right, patients are dehumanized. So we ask the question, well, do patients have rights? Right? Do patients have rights? And what are those rights? And I'm just going to leave those questions sort of open here. So what do patients deserve from their healers? And we have now, right, there is a movement, right, toward clarification of a patient's rights, right, a patient's bill of rights. What do patients deserve from their healers, right, in terms of treatment? Okay, all right, an unalienated treatment, to be treated as a human being. Okay, everybody get that? All right, so it's still kind of an issue. People are still talking about it. All right, very good. So that's that part. Now, the other thing we got to get into is this one here. Western biomedicine, right? This is the third one. This is the one I wanted to talk about. And Miller talks about these things, but I'm kind of talking about them in a different context than I think she intended. So Western biomedicine, right, as an institution, needs to improve its recognition of culturally specific syndromes. This thing that we're calling culturally specific syndromes, okay? And we're going to define what those are in just a bit. But before we do that, I want to remind you of this, right? What is a disease, right, within Western biomedicine? Well, it comes from here, right? That in Western biomedicine, panels of experts have to agree about how to label and classify health problems according to scientific criteria, right, criteria, so that Western biomedical manuals, right, tend to be biased toward diseases that only Western biomedicine recognizes, and therefore it ignores or neglects other health problems that are recognized by cultural insiders, right? Neglects problems recognized by cultural insiders in other cultural contexts, all right? So here we go again. Right, that because this is the way, right, that diseases are defined within Western biomedicine. if something is not in the medical manual, it is not seen, right, by Western biomedicine, right? Now, something to a cultural insider, right, in some other cultural context, can be very, very real and not be recognized by Western biomedicine. And Western biomedicine has to be better at recognizing these culturally specific syndromes. So, what is a culturally specific syndrome? Well, culturally specific syndromes are health problems associated with a particular culture. Sometimes they're called culture-bound syndromes or culture-bound diseases, right? These are syndromes that are unique to the circumstances of a culture. You find them within a particular cultural context. So you may find them in one, but not find them in another. They aren't universal. They aren't necessarily universal. You get that idea? Okay. So what we got to understand, right, about these culturally specific syndromes is, remember, critical medical anthropology wants to look at social factors, structural factors, political factors, economic factors, and so on. And there are social factors that produce all kinds of stress, right? Social factors that produce all kinds of stressors, right? Or produce fear or produce shock or whatever it might be. But let's just put it all under the general category of stress, right? So there are social factors that produce stress, right? Now, these stressors, right, these stresses can become manifested in real symptoms. I have it in capital letters, right? Real. It's real, okay? The stresses can become manifested in real symptoms and cause real suffering. So, in other words, the stressors become somatized. So there's a word for it. Maybe the nurses have heard that word before. I don't know. But the stressors become somatized, right, in symptoms. Now, what the word somatized means is they are expressed in the body, right? These stresses become expressed in the body as real suffering, okay? Everybody follow that there, right? So, for example, stress may cause people to get, ulcers, right? So the stress they're feeling, right, becomes somatized in some kind of physical symptom, becomes manifested. So that's what we're talking about here, right? The manifestation or the somatization of these stresses that cause real, actual suffering and death, okay, in people. And that we have to now look at the cultural context in which they arise. So we have some examples of culturally specific syndromes. One of them is karoshi, this thing called karoshi in Japan. Literally means death from overwork. So you have people who are, literally working themselves to death. And the stress of overwork is leading to, cardiac events and things like that, right? So people are literally working themselves to death from overwork. All right, karoshi. We have this thing here, susto. Susto, find it in places like Spain and Portugal, and actually you find it in other places like in Latin America and so on. And susto is called fright. Really is like translated as like fright or shock disease. So this is symptoms that follow people experiencing highly traumatic events in their lives. Okay, so highly traumatic events in their lives, and that leads to this really severe nervousness. It leads to weight loss. It leads to insomnia, right? Even things like fever, but also other symptoms like depression. Okay, diarrhea. Another consequence of this fright shock disease. So it is these physical symptoms within these cultural contexts that follow a severe emotional trauma. Okay, so that's susto. And then another one that I think is a really, really good example of a culturally specific syndrome is sufriendo del agua, which we find in Mexico among certain of the poor, right, in Mexico. I have here the Oaxaca Valley, but other places in Mexico also. Now that phrase there, sufriendo del agua, literally means suffering from water, right? So suffering from water. So it affects primarily the poor, and it emerges from the stress that goes along with not being able to adequately provide water, right, for your family, okay? And in particular, it affects women because usually the job in these among these people of acquiring water, right, for the family falls on women. So they're the ones who suffer from it the most. Not that men don't suffer from it as well, but women seem to be the ones who suffer from it the most. Okay, so this is suffering, right? Suffering that's linked to water scarcity. Okay, and it gets somatized, right, in what is called bodily distress. There was an anthropologist named Michael C. Innes McMillan who wrote an article about it. It's been written about a lot, but the one article is by this guy Innes McMillan, and he talks about how suffering from water, right, leads to what he describes as bodily distress, right? Very severe, very serious nervous tension that comes from it, as well as other things like chronic thirst. And maybe that's pretty obvious. You don't have access to water. You're going to suffer from chronic thirst. But the nervous tension leads to anxiety. Very severe anxiety leads to pain, generalized physical pain that people feel in their bodies, bodily pain. Okay. Now, so those are some of the direct, manifestations of sufriendo del agua. But then there's other things as well. There's like secondary things that follow from this, and it's for example, people don't have access to water. That means that they can't, or they don't have the ability to engage in preventative hygiene measures. Okay, so for example, they're not able to bathe properly. They're not able to launder their clothes properly. They're not able to clean their houses properly, right? And so they are open to risks of other things, like the risk of cholera or the risk of skin or eye infections, right, and other kinds of health problems. So that's sufriendo del agua. Very real, very, very real thing from which people suffer, even suffer physical pain. Okay, and critical medical anthropology should say this is something we should be, the things like this we should be concerned about. Now, we have our own, right, in the West here, and especially in the United States, we have our own culturally specific syndromes like anorexia nervosa and bulimia and other kinds of body dysmorphism. I have a quote here from an article. It was published in 1987, and it's old, but I picked it on purpose because this was about the time we were starting to talk about anorexia nervosa and bulimia. And McCorg and Taub are sociologists, and instead of talking about anorexia nervosa and bulimia from a psychological point of view. They were looking at it from a social and a cultural point of view. And here's what they said. They said, although relatively ignored in previous studies, the sociocultural components of anorexia nervosa and bulimia, the slimness norm and its agents of reinforcement, have been postulated as accounting for the recent dramatic increases in this disorder. So what they are describing there, what McClurg and Taub are describing there, is the cultural context, right, in which you get anorexia nervosa and bulimia, right, that are manifested how they're somatized, right, in actual physical suffering, and actual physical symptoms like extreme weight loss, right, and even death. People die of it, right, and to McClurg and Taub, it's related to the slimness norm and its agents of reinforcement. So it's a condition that's unique, right, to American culture and to other societies within Western culture. Okay, all right, everybody good? Okay, so that's where we're going to end this little part here. So I'm just going to say goodbye for now, and see ya for, part 9, right? Yeah, part 9. I hope I'm counting right. Part 9. Okay, so stay tuned, everybody. And again, have a happy Easter. Go bite the head off your bunny. All right? Bye-bye.